As Sri Priya has mentioned, we are more than halfway through. Okay, so most of you should be having a better knowledge of what palliative care is to how you were before we started the course. And now we are into all the nitty-gritty stuff. We have to know everything. So that is the stage we are in now. So not that we know something about palliative care. By the end of this course, God's grace, you'll be in a state where you know mostly about palliative care. That's why we are not leaving any topic untouched. So from that point of view, a warm welcome to Dr. Deepak Sudhakaran, who is going to enlighten us today about something which is not only special for palliative care, it is something which is going to be useful for one and all when they treat any patient with that complaint. So a warm welcome again to Dr. Deepak Sudhakaran, who is an active member of Palim India. And he has obtained his, he's a specialist in community medicine and working with Palim India. And he is trained from the well-renowned Institute of Manipal. A warm welcome to you, Dr. Deepak Sudhakaran, to enlighten us on the topic for today.
Thank you so much, ma'am, for that introduction. Good evening to one and all doctors over here with us today evening. Shall I start sharing my screen, ma'am?
Yes, please, go ahead.
I already gave a glimpse of delirium by using the term screening instead of sharing. Yeah.
No problem. See, that's a good start.
That's a good start.
So we are giving practical session.
Yeah. So I don't see a lot of videos on. It would be nice if many of you could come on screen so that me and Sri Priya and Radha ma'am can have some company as well. All right. Shall we start, ma'am?
Yes, go ahead.
So, as we have already said, topic for the evening is delirium. So before we start off, I want everyone to be as active as possible. Preferably use the chat box as much as you can. We will be pausing at different places. And until you interact, I will go into delirium for some time, till the time you interact. Okay. So do use the chat box as much as you can. And feel free to raise your hand if you want to make a comment or ask a question at any point of time. So with that, let's start off. So basically, delirium comes from a Latin word which means that to go off track. So here, what we mean by off track is there is a particular way in which normal human beings live, right? So we are on track all the time. We are behaving well, we talk well, we do what is required in society in the way it is demanded. And suddenly we start going off track. And that is basically what delirium means, to go off track from the usual way of doing things. So it is an acute confusional state. Okay, all of us may have acute confusional states sometime. We just wake up from sleep, we may be a little dazed and confused. Suddenly there's a loud sound happening somewhere and we are confused about what's happening. Does that mean we are in delirium? So it's an acute confusional state which is associated with a medical condition or an intoxication or a substance withdrawal. So on a background of these three, if there is an acute confusional state, then we call it as delirium. Now, usually what do we mean by the term acute? In medical terms, when we say acute, we mean right now, something starts happening right now or in a very short span of time. But in delirium, this acute may mean a few hours to even a couple of days. So acute doesn't mean a few minutes. It may be a few hours to a few days. So these confusional states develop over a period of few hours or a few days in a background of having a medical condition or an intoxication or maybe even a substance withdrawal. So what is confusion, first of all? It's a mental and behavioral state of mind of reduced comprehension, coherence, and capacity to reason. You can't reason with these people, right? If somebody is intoxicated on alcohol, is he having any comprehension where he is, who's talking to him, what's going on? No. Can you reason with such a person? No. So confusion is a state where there is reduced, the 3 C's: comprehension, coherence, and capacity to reason. So what are the features? Before a person starts developing this delirium, which may range from few hours to a few days, he starts showing some symptoms. This patient is typically restless, irritable, his sleep is disturbed. Many times, nighttime, he is not able to sleep. So these are all prodromal symptoms as far as delirium is concerned. All of us know prodrome means before the main thing hits, right? Before the main thing hits, there will be certain symptoms which the person shows. So this has a fluctuating course. That means there will be a waxing and waning. There will be some disorganized thinking which you will be seeing. There will be some incoherent speech which you are not able to understand. There will be reduced attention span. Psychomotor activity may be increased or decreased. That is, the person will be in different stages of arousal. Maybe he's hyper vigilant, maybe he's in stuporous mode, and he may have some abnormal motor movements. You may see this person is simply picking on something in the air, or he's picking on something on its clothes. So abnormal psychomotor activity. Affective symptoms, that is emotional instability. Person may show anger, sadness, very labile. Okay. Agitation, very commonly seen. Plus or minus noisy, aggressive behavior, especially if there are people who work in the ICUs, you would see such patients. Are there people who work in the ICUs over here? If you could just come and respond on the, yeah, I think I already saw 1 or 2 hands. Yeah. And there will be altered perceptions also possible, that is hallucinations. Like I said, please do respond, even if it's informal responses, please keep putting them on the chat box so that I can have some interaction with you there. Right. But if you open up Oxford textbook of palliative medicine, you will see that there are nearly 32 symptoms or 32 features of delirium. But the hallmark of delirium is attention deficit. Okay, we'll look more into it later on. So what are the causes of delirium? To make it easy to remember, there is a mnemonic which is delirium itself. So D is drugs. Like we had said, acute confusional state due to intoxication or withdrawal. So many drugs can cause it, both legit drugs as well as illegal drugs. Eyes and ears. That means people who have sensory deprivation because of some disability or disease to the eye, or the hearing disorders of the ear. Okay, so whatever is giving a sensory stimulus to the patient, if there is anything which is becoming a barrier to that sensory stimulation, that can cause delirium. L for low oxygen states or insults, like in heart attacks or MIs, strokes. If there is a pulmonary embolus, so there is low oxygen states. Infection, which can cause neuroinflammation. Okay, increase in inflammatory markers which runs through the body via blood and reaches the brain, causes neuroinflammation leading to delirium. Retention of urine or stools. Remember this one thing in a palliative care setting. One of the major questions which we always ask is, did you pass stools today? Did you pass urine today? So retention of urine and stool, which can lead to an adrenergic overdrive, which will lead to increase in certain neurotransmitter within the nervous system, which will lead to delirium. So many a times we'll see neurological issues, but our treatment may be relieving of constipation. Do remember that. Ictal states, that is post-ictal confusion, which can happen. Uncontrolled pain. the next very important, or not the next, probably the most important scenario which you come across in pain and palliative care is pain control. So uncontrolled pain itself can cause delirium. Metabolic causes like hyponatremia, okay, very common cause, hypoglycemia. So metabolic causes of delirium. And as for subdural hematomas, if there is a basically a space occupying lesion within the cranium, then it can cause delirium. So these are some of the causes of delirium, but there are many, many, many more. So there are certain neurotransmitters which you can see over here, which are responsible, not all of them, but some of them. Definitely an imbalance of all of them can cause. And there are certain drugs which can influence these neurotransmitters. We'll be looking into some of them later on. Right. So coming to burden of delirium. Nearly 30% of hospitalized patients have delirium. These includes patients in ICUs. And 85% of your patients in end of life can have something called as terminal delirium. That means this is the last delirium probably this patient may have. So end of life care is again a major element of palliative care. So here you can see its importance of treating a condition called as delirium, because nearly 85% of patients who are in end of life may develop delirium due to various causes, of course. So what is the impact of delirium? So delirium itself will cause a functional decline in the person, because the person in an acute confusional state or in a confused state, you don't expect him to behave normally, right? So especially if it's an elderly patient, elderly people are more at risk of developing delirium. They may have falls because of instability. Once they have fall, what is one of the commonest fractures in an elderly which may happen? Please start responding on the chat box. So when does that fracture or other fractures happen in such situations? The person becomes immobilized. And again, there is a functional decline. There is a rapid functional decline once a person becomes immobilized. Further risk of developing delirium. It's a vicious cycle. A person who may be agitated, angry, and aggressive, do you expect them to eat and drink well? Not always possible. You go with food, they may just hit the plate away. You go with water, they may put it back on your face. All sorts of things may happen. So hydration and nutrition will further decline, leading to further decline of the patient's general status. Emotional burden. Do you think it is easy for a caregiver to keep looking at their loved one who is behaving abnormally, and it is going on day in and day out? They are not sleeping at night. They are abusing the person who is at home. They are having hallucinations. It is a big emotional burden for the caregivers. When we say palliative care, we are talking not just about the patient, but also about the people who take care of the patient, right? So it is a big emotional burden for them. And it is also said that a person who is in delirium, he is even more distressed within himself. He is more distressed. So it becomes more important that we control the delirium for him so that we can give some comfort care to the patient as well. So what is the pathophysiology of delirium? Actually, very frankly speaking, very poorly understood, still being studied, but there is some hypothesis. Reticular activating system, right? The one which is responsible for our sleep-wake cycle, for us to be active, for things to happen in a certain order. So there is some diffuse localization which happens, or imbalance of neurotransmitters which happens in one of these areas, because of which the person starts behaving abnormally. Okay, so there you can see elements over here because of which the person may have more different, abnormal psychomotor activity, right? In brainstem, thalamus, prefrontal cortex, and parietal lobes, any of the, depending on which area is affected, there can be altered psychomotor activity. Now, two of the major neurotransmitters which is implicated is acetylcholine and dopamine. Specifically speaking, a deficiency of acetylcholine and an excess of dopamine. Okay, have this in mind. So, but not all individuals which are exposed to the same insult will develop signs of delirium. Let's look at this last statement in bold in a bit detail. So here, let me just take the marker. Yeah. So here you can see there are certain individual risk factors and there are certain triggering factors. What are the individual risk factors? Suppose a person who is of old age, a person is having some dementia, a person is having some chronic disease. All these are risk factors an individual may have. The person who is young, who doesn't have any other comorbidity, may have lesser risk factors compared to a person who is old, having other chronic issues. Now, if it is suppose somebody like me, I would like to think that I am young still. So, for a young person who doesn't have any chronic illness or other comorbidities, my individual risk factors are very low. For a person like me, to get delirium, I must have some very high triggering factor to develop delirium. In essence, what I am saying is an insult which should be done to me should be so huge that it damages me in some way that only if it is large to that extent, I will develop delirium. For example, like a sepsis, like a high-risk surgical procedure, which both of them which may be life-threatening, or some sort of drug toxicity. But if a patient is in an old age group, they have other chronic illnesses, then even a low trigger like an infection, okay, or some conservative management which you do for some illnesses which worsens later on, these small things itself can cause delirium. So in short, what I want to say is everybody, including us, is at risk of delirium. Is everyone able to follow? Is this too slow? Is this too fast? If you can just start coming on the chat box and responding, it will be a good feedback for me. So which are the conditions in which the delirium threshold is lowered? As we told, extremes of age group, okay, vulnerable population basically, the extremes of age group. Dementia, a person having dementia due to cerebral atrophy or old age. Visual and hearing impairment, like we said, because there is not enough sensory stimulation happening for the person. One common place which we see is, whenever we go in home care settings in low socioeconomic status, there'll be one dark corner of the room where the patient is lying every day, a bedridden patient. No sensory stimulus, doesn't know what time of the day it is. On the other spectrum, people who are having serious illnesses, who are admitted to the ICU, lights are always on, sounds are always on, both of them. Okay, so hearing and visual issues, alcohol abuse, depression, and reduced physical activity. All of these, especially people who are elderly, are prone for this, right? So what are certain triggering factors for delirium? A change in environment. Suppose a person who is having high individual risk factors is somebody whom you love inside your home. And for this loved one, you made a new house. Okay, you built a new house. And one fine day, as a surprise, you took them over there. You wanted to surprise them, to give them happiness. And you took them to a new house. But in a background of chronic illnesses or high individual risk factors, there is a change in environment and they become confused. They can develop delirium. Something done with a good intention can develop delirium. Unfamiliar excessive stimuli. Person in an ICU, lights are always on and monitors are always beeping. Unfamiliar excessive stimuli can lead to delirium. General deterioration of a person as old age starts happening. There is a decline in hydration and nutrition. or some other diseases which develops like Parkinson's or Alzheimer's. As time passes by, it starts worsens and worsens the person's general condition. So general deterioration. Uncontrolled symptoms, okay, especially in palliative care settings, any uncontrolled symptom can worsen delirium. Primary or secondary brain tumors, depending on the location of where inside the brain it is occurring, can lead to abnormal behavior. Paraneoplastic syndromes, which may cause some release of excessive hormones, etc., which will lead to delirium. Biochemical imbalances, as we already told, sodium, or even as simple as glucose abnormalities, and drug induced. Withdrawal states, somebody is having withdrawal from alcohol or other drugs for which they may be on treatment for it, and then there are withdrawal states. Organ impairments, for example, renal impairment, not functioning properly, leading to metabolic issues. Sleep deprivation itself can cause some major surgery, like we said, low for a person with low individual risk factors, going through a major surgery may cause, and trauma. So what are the types of delirium? Basically, it's of three types: hyperactive, hypoactive, and then mixed. Names are pretty self-explanatory. So what we see over here, you can see on the left side, the arrow upwards is a more agitated person, and the arrow below, which is withdrawn, patient is more withdrawn, looks depressed. Okay, so there is a pattern of waxing and waning. Like we said, it's a fluctuating symptom. So there will be periods of hyperactivity where the person may be aggressive or abusive. There may be periods of hypoactivity where the person is not talking much, will be simply staring into oblivion, and maybe more easy for us to manage. But in most of the patient, it's a mixed kind of delirium. I would like to ask a question. What kind of delirium would you like your patient to have? Please come on the chat box and respond. Do you want them to be in hyperactive delirium, or you want them to be in hypoactive delirium, or you want them to be mixed once in a way? Yes, Dr. Harini, none would be a very ideal answer. But just in case you have a choice.
Mixed.
Okay, Dr. Akshita is saying mixed.
Don't want hypo or hyper also.
Don't want hypo or hyper.
Yes.
Hypoactive because the patient will be easier to restrain and the chances of self-harm will be lesser.
Yeah, so this is what I was trying to come to. Thank you for the answers and response. Majority of us would want our patients to be in hypoactivity so that we can chill a bit, right? It's easier to manage. No need for us to get worked up. Like you said, lesser self-harm. But mind you, a person who is in hypoactive delirium actually senses as much distress as a person who is in hyperactive delirium. He may not express it, we may not ask it also, but the person within himself is equally distressed. And there is another fact that a person who is in hypoactive delirium, who goes untreated towards his end of life, will have a bad death. It will be a worse, uncontrolled symptoms he may have, and he may have a bad death. So that is why hypoactive delirium, it becomes important for us to identify and treat as well. Right? Hyperactivity, anyways, we will do something about it. But hypoactivity is something we'll say, okay, he is relaxing. So we need to be aware of hypoactive delirium. Right? So there are various assessment tools to know whether a person is in delirium or not. But we will be looking at very simple bedside methods of assessment. The most commonly used one is confusion assessment method, or CAM. So what we look into over here is basically this. Two features which have to be there. One is an acute onset or a fluctuating course. Acute onset, like I said, need not be a few minutes. It may be a few hours or a few days also. And the course will be fluctuating. They will say that daytime he's okay, doctor, but towards night he starts becoming uncontrollable. Give him something to sleep. This is called as, can anyone say what this phenomenon is called as? And just come on the chat box and post your answers. So fluctuating course. Second is inattention. Okay, diurnal, a better phenomena. Diurnal variation, no. So I'm telling, when the sun sets, the person starts having delirium. Exactly, yeah. So this is called a sundowning phenomena. So there will be a fluctuating course and there will be inattention. Along with these two, there will be either a disorganized thinking or an altered level of consciousness. If the first two, along with either 3 or 4 is there, then we will say that this person is in delirium. We'll look into it in more detail. Acute onset and fluctuating course, as we already told, few hours or few days. So when you ask a certain question, where are you right now? They may say that they are at home, they are at their sister's home, or they are somewhere else. An answer which is a wrong answer. They may think that they are not in the hospital. And they may say things, they may see things which are not really there. They may be having some form of hallucinations. Very commonly, we see patients becoming aggressive. You ask why they are becoming aggressive. They'll say that somebody is hiding beneath the bed with a knife. The moment you go out, he will come to poke me. So they may see things that are not really there. Inattention. A very simple way to measure inattention is you give them a 3 or 4 digit, like maybe 1, 2, 3, 4, and they could repeat it backwards. Or you tell them that Monday to Sunday, tell it backwards. Or January to December, tell it backwards. Simple things which you can assess, which shows inattention. Disorganized thinking, which is the current year, which is the current day, which is the current month. Simple questions which we ask. Where are you right now? We'll show if there is disorganized thinking or not. An altered level of consciousness. So this is again, like we said, there's a waxing and waning pattern, right? So we are seeing that we saw that the graph, there is periods of hyperactivity, then they may come back to normal, then they may go into hypoactivity and they may look depressed. So there is an array of levels of consciousness which can happen. They may be alert, they may be vigilant, they may be lethargic, they may be stuporous, where they're going in and coming out, or they may be comatose. So altered levels of consciousness. Then there is also the 480 method. It's an assessment test for delirium and cognitive impairment. So if you look into this, the score of 4 or above will show that there is a cognitive impairment or there is delirium. So here, the time taken to assess delirium is even shorter because you can see over here the alertness score. If it is clearly abnormal, the score is 4. Okay. So for normal, the score is 0. For a little bit of sleepiness, it is 0. But if it is clearly abnormal, so you are seeing the patient and you know that this is abnormal level of alertness, you give a score of 4. And right away, he is in delirium. So you can conclude the person is in delirium. So apart from that, the same way you can ask certain questions which will show disorganized thinking or attention. And if the scores add up to 4 or more, then it is delirium. So here it is more easier to conclude an easier method to assess, the 480 method. So these are the 2 very common methods which we use for assessing delirium on bedside or in home care settings. So management of delirium. So like we said, there are so many causes of delirium. There are so many triggers to delirium, depending on the kind of individual risk factors which a person have and the kind of triggering factors, they may have so many causes. So the first principle is always correct the correctable. It's a principle in palliative care. Same applies for delirium, that you correct the correctable. So for that, you may want to do some investigation. You are expecting that the person is having a metabolic abnormality in a background of a chronic kidney disease. You may want to look at their electrolytes. You are expecting that the person is diabetic and is not taking his medications well, or is taking too much of medications, you may want to look at his glucose level. You are suspecting that there is a secondary in the brain. You are thinking that maybe radiation can help. You want to do some investigation for that and see if it is correctable. So depending on the situation, you see what may be correctable in a patient and you try correcting it. So always have this in mind, correct the correctly. But there are many other things which can be done before you go into investigation and intervention. And these are like pharmacological intervention. So these are non-pharmacological interventions which we are talking about. So before we go into it, there are certain mimickers of delirium, right? So like we said, there is an altered mental status in the person. So you're not sure if the person is depressed or is he in psychosis, which you may need to hand over to a psychiatrist, or is the person having dementia, which is due to old age? You don't know, you're not sure. Or is it delirium, which you are thinking that there may be a correctable cause and you want to treat it? So there are certain things: acute change in mental status, inattention, altered consciousness, disorganized thinking. All these are the features of delirium, which may or may not overlap with the other diagnosis. So when we are talking about delirium, all of them are positive. You can see all of them are present. But in the state of depression, do you think depression will start off suddenly? It is something which develops due to certain situations in life, and over a period of time, it starts developing, right? So depression is ruled out. Dementia, do you think it is something which starts off acutely? No, it is something which develops. Psychosis depends, may or may not, depending upon what is the external stimulus which has occurred. Inattention, again, may or may not be there in all the conditions. But altered consciousness, do you expect to see altered consciousness in a person who is having dementia or depression or psychosis? These people will more or less be on the active side, or at least they are awake side. But in delirium, again, we said that there may be times when the patient will hit normal, then go down, become stuporous, become comatose, come out again, become hyperactive, go back down again. This variation will keep happening. Disorganized thinking, possible in many situations, not usually in depression. They have clear insight about what is going on within them. They will explain it to you crystal clearly what they are going through. And yeah, chronic duration may or may not be there in many situations. Delirium also can happen chronically, long-standing deliriums. Do remember that many a times delirium is not treatable. No matter what you do, it may persist. So chronic delirium is also possible. So coming to the first form of intervention which you should do for any patient having delirium, that is the non-pharmacological management. So what are the things which we can do? We can optimize their sleep-wake pattern. You can orient the person. You can make your communication better with the patient as well as the family members. You can encourage mobility in an elderly person. You can monitor their hydration and nutrition and ensure that that doesn't decline, which may lead to a general decline in their condition. Monitor their bowel and bladder functions, which to ensure that they don't have retention or constipation. Provide support and education to family members. Let's look at it in a little bit more detail. Optimize sleep-wake pattern. Many times we see the family members complaining that the patient sleeps throughout the day, and is awake throughout the night. So you have to look into what the causes are. People who are having chronic liver disease due to other reasons may have sleep-wake cycle reversal. Many a times in home care settings, like I said, in poor socioeconomic status, we have seen that the house, very ill-lit houses, not having good ventilation, not having enough sunlight exposure. In ICUs where the lights are always on, so the person is not having natural daylight, not able to see whether it is daytime or nighttime, not having exposure to the clock, what time it is they are not aware of. Right? So low level of light and noise, okay, So what we need to do is we have to increase their daytime exposure to sunlight. So we always say whenever we have patients in our IP setting, patients who are prone for delirium or who have delirium, we give them a bed which is facing the window, so that when sunlight is happening, they know it is daytime. They tend to stay awake. And at night time, when the light goes down, it becomes dark, melatonin starts getting secreted, and the person starts having his usual uh, uh, sleep cycle. Maintain a low level of light and noise. Seldom possible in ICU settings, okay? But maintain low level of light and noise, especially towards the evenings, and have some sleep protocols. There may be identify something which the patient enjoys or is soothing for the person. Some may like to have a warm milk. Some may like to have a head massage. Some may, need to listen to some music, soothing music before they go to sleep. So identify certain things which may be used as a sleep protocol for each individual patient. So optimize their sleep-wake pattern. Next is patient orientation. You have to repeatedly reorient the patient. Where you are, why are you here, who's there along with you. Introduce yourself, who you are. If possible, the same person should go every day and see the patient so that they don't get confused regarding who's coming and new people are coming and seeing me every day. Right? So, like in the movie, which is the famous Hindi movie or Tamil movie, which is there, in which the person has to keep reminding himself the purpose for which he is walking around. I think at least this movie fans should be able to answer. So one thing is you can have a visible clock in their vicinity, which they can look at, okay, so that they know what time it is. This combined with a sunlight exposure will do good for the patient. I think all doctors, very serious lifestyles we all live in, nobody is able to answer that question, which is that movie in which the person has to keep reminding himself about what his purpose of existence is. Yeah. Thank you, Dr. Ria. Oh, Dr. Ann, yes. So I specifically wanted to show this. Purpose of showing this was we are not going to draw over the patient's body or our bodies, but we can have a whiteboard on which we can write certain details, which every time the person looks at, it will remind him that and reorient him. It will remind him, reorient him, and by way of that, it will reassure him that he is in safe hands. So reorientation becomes a very important process, which a non-pharmacological intervention, which we can do for such people. Communication is essential for the patient. So by here, what we mean is good sensory stimulation so that the patient is able to communicate well with us. So it may be as simple as a person having blurred vision due to cataract. So you can get an eyeglass for him. It may be an elderly having presbycusis. So you may get a hearing aid for him. It may be a person not able to talk properly and communicate because he doesn't have teeth. So you can get a denture for him. Simple interventions which can improve communication, which will lead to lesser risk for developing delirium. Encourage mobility, mobilize the person as much as possible. If a person is unable to sit down for too long, at least sit on the bed for your meals. Avoid restraints as much as possible. Would you like your hands and legs to be tied? It's a question. Would you like your hands and legs to be tied even in normal circumstance? No. I can understand why I should tie your hands and legs. You can perfectly comprehend it, but still it will end up being an irritation to you, right? So a person who is already having abnormal behavior, who is having irritation, agitation, and aggressive behavior, do you want to tie his hands and legs? It is only going to cause more problems and distress for the patient and to the caregiver who has to witness all this. Minimize the use of catheters as far as possible because of two issues. One, it can cause infections. which can lead to worsening of delirium. Second, it will cause reduced mobility. Right. Second is next is monitor bowel and bladder function. Like I said, a person who is having adrenergic, is having constipation or retention of urine. Many a times, what we see is these go hand in hand because hard stools in the rectum, it will have a pressure effect on the urethra, which will lead to retention of urine, and this will lead to an adrenergic overdrive in the person, which will lead to imbalance of acetylcholine, and it will cause delirium. So always remember, whenever a person comes to you with urinary retention, especially in palliative care settings, especially if the person is on opioids, which may cause constipation, do not straight away go for the Foley's catheter. Ask that, did you pass stools? When was the last time you passed stools? If they have been constipated since past couple of days, go for emptying or evacuation of the stools first. Many a times automatically the urinary retention gets relieved because the urethra gets, the pressure effect on the urethra is taken away. So always remember constipation and urinary retention as important factors in palliative care setting as well as in delirium. Provide support and education. The most distressed people at these times will be the caregivers, because altered sleep-wake cycle, the patient will keep hurling abuses or calling the caregivers at night. They are not able to sleep. Conventional mode of management in hospitals may be to give certain medications and to tie their hands and legs. The person may be distressed to see this. So involve the family members. Tell them what delirium is. Tell them what the causes of delirium in that person probably is, and tell them how you intend to approach it. So educate them. Okay. Ask them to reassure the patient whenever the patient may have certain hyperactive episodes or an hypoactivity. Reassure the patient, reorient the patient, and reassure the patient. And once you educate the family, many a times they understand what the patient is going through, and they are okay with it. At least up to some extent, their distress is brought down. We are talking about the caregivers over here. Okay. Now, after all this, you tried all this, or many times these go hand in hand. Now, we doctor want quick solutions. We know that many things are not practically possible many a times. A person who is at home, the only entry to the home is a door. There is no window inside the house. So what do? We can't expect them to sleep near the door. The condition is going to remain the same. We may want to do a pharmacological management. Anytime in ICU settings, you may not be able to do anything. Okay. Machines have to go on, lights have to stay on, people have to walk around. So such situations, many situations where non-pharmacological management may not work or may alone not work. In such situations, we would like to go for pharmacological management as well. So in pharmacological management, the drug of choice are antipsychotics. But who are the patients in whom you want to use antipsychotics, or you may prefer to use these medications or pharmacological management? One, as we already said, non-pharmacological methods have failed. Second, the patient themselves is distressed. Okay, because of their anger and agitation, the patient appears distressed. The patient is a risk to themselves or others. They are having hallucinations. They may hurt themselves, or they may hurt their caregivers, or the patient who is lying down on the next bed. They are having an agitation. Basically, if there is perceptual disturbances, that is hallucinations, or if they are having agitation, if such situations are there, you are going to go for a pharmacological management. And the drug of choice is haloperidol. Very commonly we use. It can be given orally, subcutaneously, and IV as well. So many a times at home, there are situations at home also where we can give subcutaneously. Now, many times due to agitation, many of these patients have agitation. We may straight away tend to use benzodiazepines. So remember that only when there is hyperactive delirium, will we use benzodiazepines. Otherwise, benzodiazepines may worsen delirium. Hence, majority of the times we choose to use only antipsychotics. But whenever the patient is too much into an aggressive state or an hyperactive delirium, which is unable to be controlled, and you really want to give some sort of a sedation to the patient, then we'll think of using benzodiazepines. So now these three drugs, there are quite a few drugs which we use for the treatment of delirium, but the ones in the red boxes are the ones which we very commonly use. Okay, looking at the situation also, because all these drugs have certain side effects as well. You can see over here, haloperidol has got a lot of extrapyramidal side effects. Okay, so as you know, a person who is having Parkinson's, he already has extrapyramidal side effects. When you give haloperidol on top of it, it may worsen the Parkinson's symptoms. Depending on the situation, you may have to choose which drug to use. Quetiapine. Quetiapine is a drug which has a sedating effect as well. So when many a times in sundowning phenomenon happens, right? Patient is not sleeping at night. Family members are distressed. In such situations, you may want to start on quetiapine instead of haloperidol, because it will give an effect of sedation also to the patient. But again, there are certain anticholinergic side effects to quetiapine, like dry mouth, etc., where the person may, if already he has a background of dehydration or certain situations like that, where anticholinergic symptoms are there, then quetiapine may worsen that. In such cases, you may have to go for haloperidol and may give a small dose of maybe a benzodiazepine, which may just initiate sleep for the person. You can also go for atypical antipsychotics like quetiapine and risperidone. Both are atypical antipsychotics, which have lesser side effects, a lesser side effect profile. So what I'm trying to say is, you may have to look at the situation and choose which drug to use. So what are our conclusions? One thing is, always correct the correctable. Okay. Look at what are the issues which a person may have. Look at what are the investigations which you may want to do. Again, in palliative care settings, at least in the settings which I work in, majority of our patients are from poor socioeconomic backgrounds. And from what I understand, many of the patients who end up in a hospital also are not that well off. They may have multiple comorbidities. So you may want to judiciously choose what your investigations are. And if that investigation is going to yield any result, which you may be able to correct. Right? Go for non-pharmacological management as far as possible. Okay. There are many things which you can do to regulate the sleep-wake cycle, orient the person, educate the caregiver, or simple interventions which you can do, like getting an eyeglasses, hearing aid, or dentures. Simple things. Okay, so non-pharmacological management. Many times a multidisciplinary approach may be needed. You have no idea. You may need a specialist opinion. Is there something bigger going on which we need to look at? So many times in our patients, we are not able to figure out. So we may have to take a internal medicine opinion. That is there something which we are missing. So multidisciplinary approach may be needed. Many times you may need a psychiatrist involved. Next is always communicate and take the caregivers along. Remember that they are equally, if not more, distressed, because seeing their loved ones like this is not easy. So make sure that you take the caregivers along, and never forget, identify hypoactive delirium and start them on pharmacological treatment early on itself. So hypoactive delirium. So I think we can look at few.
Thank you very much. Like mainly few salient things I would like to say. Your important slide, I would say, everyone is at risk. That is something everyone in this group has to take into mind, that the individual factor and the triggering factor. See, many a time they are like opposites. In elderly, especially, see, palliative care is just not cancer care alone. First, that by now all of you would have got it. And having that in mind, you can just have any elderly at home, 85-year-old, okay? Just one bout, or like for them, like extremes of age, one bout of diarrhea is enough to push them into delirium. Or confusion at least. I wouldn't say, I wouldn't use a big word delirium now. Just confusion, nothing more. They would have had 3-4 episodes of diarrhea, all electrolyte imbalance. They would have already been on slightly on hyponatremic. So just a little bit more of that can cause. But if it is not picked up, then it can be detrimental. So that slide, please, that is one important take home, I would say, because you see many patients and you, at the end of the day, I want all of you to be able to manage anything. If you're a well-trained physician, you should not be scared. You should be at least able to pick up something and treat by yourself, or at least direct them to the right place. So this small, just an infection, if many would know that, just one small infection is enough to make them confused. So that is one thing. And then next important thing, I would say, the whole topic, he has dealt it very well. Very salient thing is this day-night, losing the day-night rhythm. Okay, in ICU, it's very common. And at home also, it's very common. Why? Because they are bound to one room. And so if there is no window, see, many houses may not have. See, you have to learn to cater to what is needed. And I will do everything only if I have 10, if I'm like a 5-star means that won't work, please. You have to be able to manage and treat anything and everything. So if they are restricted to one room, this losing day-night is very, very common. Just 2-3 days is enough to push them. So non-pharmacological means just think. You need not have like hi-fi gadgets. Just you've got a very hi-fi gadget in yourself. Use that. And then you will be able to manage. So in that, non-pharmacological is more important and dealing them. And one last thing, there's something called as sleep hygiene. All of you might know, but if you don't know, you can have a look, because very many come up and say, oh, I can't sleep. Okay, slowly, next question, what is your normal routine? I will be looking at internet and go to sleep only 3 a.m. every day. So that person can, any method of thing you do, no big hi-fi doctor can treat that. Okay, unless you pick that up. Every day someone goes to sleep only at 3 a.m. How on earth their sleep pattern will be good? So like that, sleep hygiene is something everyone. So it is something very simple. So if you, I'm not going to be telling about that also. Like if you all have a look, if you don't find something or anything, then I will tell. So like that, teaching little things. There is ocean of information, and you have to know, like, see, if it is something, because I had a patient, what I'm telling, I don't say anything out of the blue, dear. Only what patient. So this was a 21-year-old who came up telling to me, oh, I am totally deprived of sleep. And next question, tell me what you do. That is the answer I got. Every day I go to sleep at 3 and I sleep till 12. Okay, then no one can rectify that until it is rectified by that person properly. So we have to teach them. So we have to teach many things down the line. So like that, every little things are important. So from here, either if you want to ask question, just few minutes, we can see if someone has a burning question, want to ask straight away, go ahead, or we can go to the case discussion and come back also, case presentation. Anybody wants to ask something straight away to faculty, you can go ahead and ask, or what is your take at present?
Can you Ma'am, sir, can you show me the slide on the mimickers of delirium?
That was a good compare contrast. It had all features also. So to a certain extent, you can, like differential diagnosis, you would be able, you can, from what was there, you should be able to do. Yes.
Why I wanted to see this slide was that, most of the times, sometimes if they're agitated, we say they are psychosis, and if they are in a hypoactive delirium, we call them as they are depressed, or, they have dementia. So I just wanted to see the difference, because sometimes when patients are agitated, we consider them as psychotic behavior. So I just wanted to see the difference more.
It's a fine line. I will leave Dr. Deepak to go ahead. Otherwise, let him say.
Ma'am, so you're asking between psychosis and hyperactive delirium, is it?
Yeah.
Yeah,
That was the question.
so what we are expecting is in delirium, we are expecting that there is a fluctuating course. So there will be a waxing and waning which is happening. So and as you know that that is one of the diagnostic criteria as well for the delirium. And put into this background of either the medical state which he is in, either a chronic illness or some intoxication or something possible, then it is more likely that the person is in for a delirium. But for a psychosis, this person will have a constant state of being in a particular level of consciousness, which is usually above the normal range. That is, he is either vigilant or hyper vigilant, alert. Usually, it's like that.
Also, the altered level of consciousness is more evident in a delirium. So
yes, and psychosis, if you don't mind, dear, yes. Psychosis, definitely they will have a background history. One of the things what he said, you have to remember, psychosis doesn't come out of the blue, whereas delirium can happen like that also. And you like overall full history taking is very important before you come to the point. And very salient features will be there to differentiate. I do agree that they may mimic, but when you take everything into consideration, it will be possible. And psychosis having delirium, and it will be mostly a hyperactive one, and they may be many times be harmful. So you have to make sure protection for yourself and the patient is taken, and you may need some extra help also in dealing with such situations.
So also, this is where a multidisciplinary approach becomes important. Anytime you are in doubt, go for a referral or go for an expert opinion.
Definitely true. That's what I was trying to say. Either you find out you're able to manage, or at least try to send them to the right person so that they are managed and sorted. So that is very, very important. And there was a question in the chat box about alcohol withdrawal tremors, and will that management be different? Will the manage vary greatly?
I'm not too aware of the nitty-gritties of management of alcohol withdrawal. Okay, I don't have much experience in our field level, at least. We let the psychiatrist handle is what we usually do. As far as
I would also, that is a long drawn process with alcohol de-addiction. Okay, yes. That doesn't happen overnight. And as he mentioned, you have to be very careful with those type of patients. So anyone who has any such type of habits, we will be fooled easily. So it is always better to leave it to the expert. So always multimodal management is what will come handy there.
Thank you, sir.
we hope you're satisfied yet. Maybe we can go on with the case and then go with the discussion. Will that be okay?
Sure, sure, ma'am.
Okay, go ahead.
Automatic lock ಆಯ್ತು.
Dr. Harley, can I go ahead, ma'am?
Yes, please.
Very good evening to all of you, Dr. Radha ma'am, Dr. Deepak sir, Shri Priya ma'am, and all my dear colleagues. I'm Dr. Harini from Bangalore. My case is about a 70-year-old male who was posted for wound debridement for cellulitis of his left lower limb with diabetes and with hypertension. His presenting complaints were he had confused speech since 2 days, he was restless since 2 days, and he had a history of agitation and self-harm since 1 day. Now, the 70-year-old male is a known case of diabetes and hypertension. He was admitted 3 weeks ago for swelling and redness of the left lower limb. He was diagnosed with cellulitis and he was taken up for surgery for fasciotomy under spinal on emergency basis. Perioperatively, he had poor BP control, poor blood sugar control, and eventually 3 days later, he had to be posted for wound debridement under spinal because of poor wound healing. His intraoperative course was uneventful, but again, in view of poor wound healing, he was posted for redebridement. So he was posted for surgery totally 3 times. And on the 3rd time, on table, he was very restless, he was confused, and then he was shifted to the SICU for observation. The nurse in the SICU reported that the patient was very agitated and he was trying to pull out his lines and causing harm to himself. On examination, this elderly male was a frail build and he was pale. He was appearing restless and agitated. In his vitals, his BP was 160 by 100 and pulse rate was 102 beats per minute. Saturation was 94% in room air, and he was tachypneic, having a respiratory rate of 28 cycles per minute. In the systemic examination, he had no orientation to time, person, or place. He was confused and his speech was irrelevant. The other systemic examinations were normal. In the investigations, his hemoglobin was low and his GRBS was 300, though he was on sliding scale, and his sodium was 128 and potassium was 4.9. ECG showed sinus tachycardia. He was on the following treatment. He was on IV antibiotics for cellulitis, and he was on treatment for hypertension with amlodipine and atenolol, and he was on insulin. And for the treatment specifically for his symptoms of delirium, he was moved to a quieter corner of the ICU away from the beeping monitors, and he was given 5 mg of haloperidol IV stat followed by SOS dosing. Psychosocial aspects: this elderly gentleman had lost his wife 2 years ago. He was living alone with his sons looking him up occasionally, and he was undergoing repeated surgeries, and because of the prolonged stay, it was making him worried and depressed. The main concern here is the state of delirium can lead to self-harm. It can also point to underlying organic causes like dyselectrolytemia, can lead to falls and combative behavior, and can also lead to aspiration pneumonia. So delirium is an acute disorder and it goes vastly unrecognized and untreated, especially in the wards. The sisters are not aware many of the times. With early recognition and prompt measures to treat it, the morbidity and mortality associated with this situation can greatly come down. So the points with regard to this patient story is his prolonged hospital stay, his repeated surgeries, his belonging to an elderly age group, his poorly controlled underlying comorbidities. And what we could help in this case is by reassurance and by orienting the patient regularly to where he is and what is going on, correcting the underlying pathologies, and striving to move him out from the ICU towards the ward as soon as possible. Thank you.
Thank you, Dr. Harini. I would like the other participants to take this up as if it's your own case. What all are the things which you want to know more about this patient, about what was done? You can either raise your hand, unmute yourself, or use the chat box.
Sodium level was low. Was that corrected?
Yeah, there was a correction was going on for the dyselectrolytemia as well.
Okay. Now we'll have to see whether after the correction, whether the delirium is still there or not. Because most of the time, hyponatremia causes delirium.
Yes, sir. So in spite of the ongoing correction, his situation continued to be the same. So
you have to give some time for sodium correction. That also you have to give. It's not like quick fix. Okay.
yes,
It is not given also. Being an anesthetist, you don't rush in.
yes,
Okay. So you have to give some time for that. And that is one of the thing. And if you wait and watch on that, he will respond. And the haloperidol, 1 dose only you have given. You can give SOS dose
yes,
to keep him comfortable and do all other measures also. I
Yes.
would say like our main topic today and your case presentation, they are enhancing or repeatedly enhancing what we learned. It's like we are having revision in our session itself. All what was told is what you have also brought up. So I felt that it's a very good revision. So none of us don't forget anything. We're already revising through the topic time itself. Each one, like you have to go ahead. Anybody else could.
I think there's a chat.
Something in the chat
Dr.
box.
Shweta is saying that high sugar level despite of the insulin which was given. How was was it managed up to a satisfactory level? How was it?
He was initially on the sliding scale, so then he was brought on to an infusion to get under control.
All right. So infusion ensured that the
Once
sugar
he
levels
was
came
moved
down.
out to the ward, his symptoms started gradually reducing and he was better.
Okay.
With the sliding scale, it did come down.
No, ma'am.
No, sorry. With the infusion, I was about to ask you, with the infusion, it did come
He
down.
had to be shifted to an infusion later.
So then hopefully when you start the infusion, you'll be checking the blood sugars more often.
Yes, ma'am.
So that, so when you are on that, and then you can titrate it accordingly. So as depending on your result that you get, you would titrate the infusion accordingly.
Yes, ma'am.
Dr.
And
Surbi
there's
is
a
asking,
question if there's urinary. There's a question in the chat box.
was there urinary retention for this patient?
He was catheterized because of his lower limb surgery.
Okay.
And to monitor his urine output, he was catheterized. So there was no urinary retention.
Okay.
What was the surgery which was done exactly?
Initially,
Debridement.
it was the fasciotomy, and then he had two wound debridements, sir.
Okay.
This hyperactive delirium, then we can add benzodiazepines, midazolam or something, or we can use on haloperidol.
So I just want to ask about that as well. Dr. Harini, you said that 5 milligrams stat of haloperidol was given.
Yes, sir.
So what was the response of this patient?
With the first dose, he did not show much response, sir. With the subsequent doses, which was given 4 hours, 5 hours apart, he started responding.
Okay.
Along with other non-pharmacological measures.
Right. So I was just about to ask that in this kind of a case, do we really expect that only with antipsychotics the patient is going to start becoming normal? It's going to be a no, because multiple comorbidities, like we said, high risk individual risk factors, right? 70-year-old going in for another high risk triggering factor, which is a surgery, and that too multiple surgeries, right? Dr. Shweta has brought out an important point which we usually don't look at. An isolated patient with nobody to take care of, unfamiliar surrounding, which is a trigger. So many factors in this case, cellulitis, which is an form of infection, could have, it could have worsened, was started on antibiotics, right? But that itself is a trigger. So multiple triggers in such a case. And you already said, I think the timelines which you said, can you come back to that? It's a perfect example of
Yes, sir.
what we said in an acute onset. It may be, it doesn't always mean it's a few minutes. So here you can see it's agitation and self-harm. It's a couple of days.
Yes, sir.
Right? It's a couple of days, developed over a couple of days. Dr. Shweta is asking, was any family member counseled regarding the situation?
As he was in the SICU, his family members were counseled on a daily basis. But the problem is he could not be with his family. He was away from his family.
That is what, no, like, especially when they are in ICU. See, we know that they are okay, but the patient per se, no, that's why allowing them to, like, you have different types of, in the ICU itself, you have different setups where you see, he is not typically an ICU patient. We would say a high dependency patient. He is not put on a ventilator or something. So those type of patients, either see, and next is workload. You cannot expect the nurse to look after everyone, sit and talk with everyone, then the ICU work won't happen. I know these are all where, like, you have patient nurse ratio, patient doctor, these things, nitty-gritty stuff are there. So allowing one family member to come and hold his hand and talk to him for a few minutes will do more wonders than haloperidol.
Yes, sir.
But I know it's not practically possible at times. So that's why when you see and pick up something like this, would be ideal to get someone to just come and have a chat with him, to reassure him that they are there around. They are not at home. He's not there left alone by himself. Multiple factors, all as Dr. Deepak said, no, all individual factors are in the high risk. And triggering factors are also high risk. So you're having a very great combination to cause all factors and to have delirium in all full form. So when you go treating also, you have to look into each element of it. So that is why it's a really a good one to what you have learned today, to put that into practice.
So I just want to share a small personal experience also over here. We being doctors, many a times, people who know us, either friends or family, somebody whom they know is in an ICU. Okay. And they will call us to find out, can you contact somebody in the doctor's team and ask what is going on? Happens very commonly. So many a times I don't wish to entertain this because we know that in an ICU, there is a daily rounds which is happening. There is a daily briefing which happens, right? So probably, I mean, it is just like probably they just want some reassurance or something. But once I was on the other side, I was in the counseling room during my palliative care training, which was in 2019. And that time there was an ICU in charge doctor, and then there was a palliative care team. I mean, we had pushed a lot to get the two teams together, that these counseling sessions should happen together. But I was just very amused to listen to what the doctor was sharing. I mean, we all are doctors. We are on the same side. So the doctor was talking all technical jargon, like these levels have come up, these levels have come down, the vasopressors are going, and this thing and all. So I am like, even for a doctor, it is little difficult to understand unless you are core into that field. So what is the implication of all this? This becomes very hard, and many a times the patient's caregivers don't ask. What I've heard is in government settings, there is no time for the doctors to talk because there is so many patients, right? There are so many patients. The burden is so high. So of course there are systemic problems. Me coming from a community medicine, public health background, I'm aware that there are a lot of systemic problems which is there, which needs to be dealt with. But one thing which we can do for the caregiver is that just bring down the jargon, just make it to very simple terms, which you think that you are explaining it to a school child. What are the things which you are going to say? Minus all the technical terms, and just make it that simple to them, make them understand. And 100% it is going to be solace for other doctors that they will not get calls saying to explain what is going on inside. I mean, you will take the person into confidence. Once that taking into confidence is done, then the patient is going, the caregiver is going to take you for your word. What you're going to say is what they're going to believe, and many a times they are in that state where they are not sure if they can decide, especially in palliative care settings, where you want to, if possible, de-escalate care many a times. You may want to de-escalate care so that the person has good quality of time with their loved ones rather than being in an ICU, going through a struggle which may not yield results. So when such situations you'll have to address, you have to take the caregivers into confidence. That will happen, will definitely happen with good communication.
Exactly. That's what I was coming to, Dr. Deepak. Simple, clear. Okay. Your thing, literally a week or 10 days ago, I had to speak to one of my friends who had a patient in ICU. Like I did not, other way, I said, rather than speaking to the doctor, I explained to them, okay, many times, everyone is running short of time, okay, but time is precious. If you take the effort and spend 5 minutes and explain things clearly, and many people ask me, why was I not told like this by that person? I would say, don't worry about that. Now you have got the information, be happy with it. Don't keep on questioning. So like that, try to explain with simple words and simple terms. And next, always give them the opportunity, maybe because these are all highly stressful situations. What I normally would say to all my patients whenever in ICU, I would say, okay, I've explained everything to you. Take your time, go back. Definitely, you will get 10 more questions. When you go back, sit and start thinking. Come back and ask me. See, when you're in a state like that, they have to take in and also ask questions to us, which is too much. So we also have to become expert in communication skills. Be clear, no beating around the bush. At the same time, you have to judge what they can take, what they can understand. As he said, jargons is one thing, and more than that, simple terms also, sometimes we take for granted everyone will know something about it. We being in our field, we may expect that, but that may not be true. As Dr. Biju Raghavan said, don't assume. If you ask, do you know what I'm telling? If you don't know, please tell me, I will explain. So like that, use simple terms, simple things. But what we have to say is very concrete, very confidential, everything is there. So it has to be done and dealt appropriately. Time factor has a big role. Time and patience is what is needed, because we have to do the best. Good quality of life is what ultimately we are all looking at. And with this delirium, like I being an anesthetist and intensive care, I've had various experiences. One little experience I will tell you. When they are in state of delirium, sometimes you may have male and female patients. Like in ICU setup, you won't have a male ward, female ward. So we have had such tough situations also. One hyperactive delirium, I had to give midazolam. And then I had to, because he was so, when they are in that state and you give midazolam, it'll dampen down their sympathetic drive and things. So then we had to just assist his ventilation also. Not that he did go into respiratory arrest or anything, but what I'm telling is all that is possible. So that states they can go. So like that, because we don't want this patient going and harming another patient. So these things are very, very common. Post-operative situations, it's very common to see. And especially if, as exactly that important thing, again and again, I'm coming to that slide. Individual factors, triggering factors. If you have wrong combination, that's enough for creating trouble. So that is what you all have to have in mind. Really very, very, very well presented and dealt with Dr. Deepak, and the case was also so appropriate. So like as I said, we had a revision. You told them and they themselves answered. So I think you should be happy.
Ma'am, I just
What you have
want
said
to,
has gone through.
yeah, I think is there more questions or something? If not, I just want to share something.
There's nothing in the chat. If anybody else has anything, ask. Otherwise, you go ahead, please. Dr. Deepak, go ahead.
Yes, ma'am. So I just came across this on Twitter a few days ago. I just looked it up right now. So this is a prescription from Apollo. So the patient is a 36-year-old, has come with insomnia for 6 months, inability to fall asleep, frequent awakening at night, total sleep duration 4 to 5 hours, feels tired during daytime. Okay. So what was the treatment which was suggested? Switch off internet, keep phones in silent mode from 11 p.m. to 6 a.m. Dinner before 8 p.m. Short 10-minute walk post dinner. Avoid late night parties. Brisk 40-minute morning walks. No need for medicines at present. Now this person went for a review and reviewed. Sleep quality and quantity have both improved. So just to highlight the importance of like we said, one is identifying sleep protocols, non-pharmacological management, and ma'am was saying sleep hygiene. Simple.
See, that's what I'm blown out, Dr. Deepak. What I told, exactly. I'm literally spellbound. This is exactly what you have to say, and such a nice thing to see. Many times, no, I'm really.
Especially from a corporate hospital, many times you would see something, at least for the sake of the patient, will be given, but it is so judiciously done.
This is what is sleep hygiene. You have made their job very easy, Dr. Deepak. Very well done. You're right. At least one Restil or some prescription would have been there. So this is really, really very good. This is what is needed. So we are all heading in the right
today's
track.
world, where there is a sort of an impression which is happening that doctors will anyways prescribe something or the other. They just want to
No.
This kind of stuff. So this is a time where we should be more judicious in the way we approach patients. Time where India is also becoming a country where litigations are happening, and forget about litigations, just the attacks which may happen to doctors.
Ethical, no? You don't think about anybody else. You look into yourself. Am I satisfied doing what I'm doing?
No, it is very difficult to give a prescription like this. And I don't think all the patient will adhere to this prescription. If they are going to follow it, then it's well and good. It will be corrected. But some definitely need a little bit of sedation to sleep in the beginning to break down the cycle, because the sleeping pattern is being changed, and we have to bring back the breaking down the habit, and the cycle will be done only by a pharmacological addition.
Yes,
so this prescription may this prescription may not help everybody, only those who adhere to the prescription.
Of course, this is not a blanket rule or something. As you said, this is how you have to look into the situation and do.
Yeah.
This may be a 36-year-old who was willing to do it. It's as simple as that.
Exactly.
But this is a good example. That's all that we are seeing.
And Dr. Umapati, I think, is that right? Or
yeah, it's right. It's one of an example, but not everybody can be done with this.
I too don't disagree with you, but at the same time, you can give it a try. And in that time, you can find out why is that they're not able to follow this. Okay. Everything matter of time. See, sometimes, no, like even many situations are like that, but you have to deal with each one separately, but tell them this is the option. You give it a go. If you don't find any benefit, come back in 1 week's time, and then we'll have another discussion and see. Because starting something on and then getting them off it, again, that's also an issue. It is not easy either way. So take one at a time and eat. Not all of us are not the same. That is something very, very important. That is a charm in our whole profession. If all the same. And
I didn't say it's going to help everyone. It will help, but not everyone, not applicable to everybody.
Definitely. That is why
we trial and error.
We thrive in that only. The
Correct.
plus and minus for our profession is there. That is
Correct.
what it is.
Yes,
Well
ma'am.
taken up.
In addition to what is written on the prescription, maybe he would have talked to the patient more, you would have talked to the patient more. That is more important.
Assurance. Oh, he told
Yeah.
like that. So I
No,
don't
no,
have
I
any.
said, no, ma'am. I said the doctor would have spoken to the patient in detail, what is the importance of
Exactly.
sleep
I'm coming
hygiene.
for that only.
Yeah.
The patient-doctor rapport,
Yes.
the confidence that he obtained from him. See, medicine, I would say medicine does 25%, 75% is the patient-doctor relationship which does the trick. So that is one thing good only, So, and they are so convinced, and you see them all through your life, they remember you. So it's a good thing. Everything has its own plus and minus, and then we deal with it accordingly. Very good. Like it's a wonderful session we have had. Not only the topic, we had lovely other stuff also. Like every session is really interesting because of the interactive nature of the session. That is what makes it interesting. So I should really thank all of you to be willing to do it, because it's a two-way thing. No, all of you are all, end of the day, I want all of you to benefit out of it. Over to you, Shri Priya. I think there's no more. I'll just check. Yes. Thank you to Dr. Deepak is what is mentioned in the chat. Really, thank you once again, Dr. Deepak. Really a wonderful session.
Thank you, Dr. Deepak. I personally know that he was just back from a home care visit, very tiring home care visit, and still you found out time and you interacted so much actively with this batch, even though there was some hint of delirium at the beginning. Thank you so much, Dr. Deepak, for your time, valuable time, and thank you participants for making this session interactive as well. So with a positive note, this is Sri Priya along with Dr. Deepak Sudhakaran and Dr. Rata Venkatesan signing off from the Tips Eco Hub. See you in the next session with another different topic and an eminent faculty. Till then, everyone, stay safe, be happy. Take care. Bye-bye.
Bye.
Thank you, one and all.